So I'm going to talk about vaccination and community protection. And what I want to do is talk about, first of all, give some sort of historic examples of why it's important to maintain high uptake of vaccination. Right? That's one thing, both from historical and current examples. Another is talk a little bit about how community protection or herd effect or herd immunity, there's a lot of different terms, how that actually works. It's relatively simple. And then just share with you some studies that we've done for influenza showing really pretty rigorously that herd or effect or indirect protection can be achieved. So this is a sort of a very sort of classic definition of herd immunity or herd effect. That is the resistance of a group to attack by a disease to which a large proportion of the members are immune, thus lessening the likelihood of a patient with the disease coming into contact with a susceptible individual. And it's probably just very easy to see this in this figure. So consider the people, the little circles in black are index cases. So that's individuals who are actively infected. In white are people who are totally susceptible. Okay, so you can see here that the black dots are going to transmit their infection to the white circles. Okay, so the next step is just to start to vaccinate. And if you can vaccinate enough of these white circles, they become gray, and they were vaccinated, so they are immune. So they're not going to be susceptible. So when that increases in the population, you could see that it's much less likely that one of these sort of black circles, that's an infected individual, will be able to transmit successfully to the white circle because there's so many people that are protected. And that's essentially how herd immunity or herd effect works. And there's sort of two ways that this could happen. One way is just by getting a lot of these white circles and just bolstering the vaccine, just vaccinating so much that there's just no way that transmission can occur in a population. Okay? Another way is to vaccinate them, but vaccinate them with an agent that will render them immune, but it will also be transmitted to some of these white circles indirectly. Okay, and a good example of that is oral polio vaccine, right? That it's fecal oral transmission, so it protects people who got the vaccine, but it also goes through sewage, etc., and could establish herd immunity and protection in people who never received it by that mechanism. So just some historic examples. Smallpox is one of them that was eradicated because of herd effect. So huge campaigns in the 1960s to mass immunize populations really was instrumental in reducing smallpox, obviously a very, very horrible disease, and this is probably one of the most important sort of public health success stories. And I'm showing this slide because it's a sort of Canadian example of vaccine preventable diseases in Canada in the pre-vaccine era. And I'm showing gross numbers. I'm not giving incidence or whatever because it's easy, perhaps easier to appreciate the burden. So if we look at diphtheria, between 1925 and 1929, there were over 9,000 cases. Measles in the 1950s, 61,000 cases. Pertussis, almost 20,000 cases over a 4-year period, and paralytic polio over a 4-year period, 1,500 cases. So huge burden of these relatively terrible diseases in the pre-vaccine era. And this is a pseudomembrane of diphtheria, so it's caused by a Corynebacterium diphtheriae that produces a toxin that can affect the heart, the nervous system, leading to death. So clearly something that could still be around if people weren't vaccinated. Measles is another one. So there are groups that are high risk for complications, young children, adults, pregnant women, people who are immunosuppressed, and very serious complications, including encephalitis, pneumonitis, subacute sclerosing panencephalitis, so very, very severe neurological complications. And we've seen a resurgence of measles, both in the U.S. and Canada, particularly this outbreak that I'm sure most of you have heard about from Disney World, where there have been a sort of a number of cases. There's a case that index case in Quebec brought it into a school that for probably their own religious reasons, weren't immunizing the kids, didn't believe in childhood vaccination and because of this, there were close to maybe 100 or even over 100 cases of measles in this school. So interestingly, the CDC did a brief survey looking at reasons why people weren't receiving the measles vaccine, and one of them was for either philosophical or religious beliefs. And as I was reading this, I was sort of thinking about something related to this. It would be really interesting to do a sort of a module where people who are really hesitant, right, not people on the extreme view that might go either way, present them a module and actually randomize people to a module doing pilot work before and see if that will change their mind. There was actually an interesting study that appeared in Science actually in December, where what they were doing was talking about gay marriage and whether presenting information about gay marriage to people would change their mind. And they had extraordinary success. The only problem with that is the guy who did the study was faking the data. So I spend a lot of time on these websites actually that go through these papers that have been retracted. It's called Retraction Watch, and it's actually a lot of fun to see how people actually do various types of analysis to actually disprove things. But that's sort of tangential. So I think some sort of study like this would be of interest here. So examples of things that cause tremendous problems in certain parts of the world now include polio, paralytic polio. In North America, no need for the iron lung anymore. The spread is fecal-oral, hence the sort of posters in 1915 asking people to sort of clean up and keep clean, and very dramatic reduction in epidemic polio with the inactivated vaccine and the oral vaccine. Unfortunately, in countries that are relatively unstable, like Afghanistan, Pakistan, and to a lesser extent in Nigeria, they're considered endemic, and there are still cases to this day. So another question. So we discussed briefly that herd effect or herd immunity could be achieved either just converting the susceptibles to non-susceptibles, and also by actually having an agent like oral polio that actually spreads to people and renders them non-susceptible. Another question is, what thresholds do we need to achieve community protection? And this is interesting. A lot of the work is done by mathematical modeling, and basically the magic number is something called R0, which is simply saying if you have an index case, how many secondary cases will arise from that, okay? And as you can see here, the greater the R0, the more the number of secondary cases, the higher the threshold of vaccination, the higher the uptake you need in the population. Okay? So if you're talking about something like measles or pertussis, you really need a lot of people to be vaccinated, which comes back to the point that people who refuse vaccination are being, their kids are being they're being protected through herd immunity from the parents who vaccinate their children. So now I'm just going to go through an example of influenza, and this is sort of our interest in herd effect has been to actually try to demonstrate in real life with real patients, not mathematical models, not simulations, can herd effect really be achieved? And this is the sort of data from a famous study by someone called Arnold Monto, where he went to Tecumseh, Michigan, and he said, I'm going to really find out who gets the flu in Tecumseh, Michigan. Basically did a series of serological studies and swabs and found out that the highest attack rates were in young children. Following that, there have been a series of studies that sort of asked the question, well, okay, so if young children spread the flu or they have high attack rates, is preferentially vaccinating or targeting them for immunization, will that have an indirect effect on people who might not respond as well, as Dr. Rosenthal mentioned, who might not respond to the influenza vaccination? So what this person, Dr. Reichart, did a very interesting person who started off life as a biophysicist and decided to spend his remaining active years answering the question, why do people die more in the winter? Okay, and it led him to studies on influenza. And so what he did was did a very nice analysis of a policy they had in Japan where in the 1950s school children would be preferentially vaccinated and looked at the effect on excess pneumonia and influenza death in older adults. And as you can see here, after the Japanese government instituted this policy, the excess mortality, pneumonia and mortality dropped significantly in older adults. And when they decided in the early 1990s to drop the policy, it went up again. So that was sort of good evidence, but it's wasn't sort of as concrete and in the hierarchy of evidence, randomized controlled trials are really the sort of top dog. So we wanted to do a randomized controlled trial to say, okay, if we look at a whole bunch of communities and we vaccinate the kids, can we randomize little communities and see that if there's a certain uptake that's achieved, we will be able to indirectly protect people who weren't vaccinated. Okay, so we said, okay, let's do this. Let's go to Saskatchewan because it's in the boonies, and there's communities that aren't so isolated, and then flu circulates. So we got line lists of all the little towns and cities, got all the little red schoolhouses in Saskatchewan, and I said, wow, this is great. We could do this study. It'll just cost $60 million because to swab all these. So we thought, oh, well, this is not going to work. But as we were going down our lists, we skip this slide. We found these communities of Hutterites, okay, who live in little communities of 80 to 120 people. And we said, aha, this is ideal. These are homogeneous communities. When they get so large, they actually break off. They draw straws literally, and one colony will butt off and become another colony. So this is a great opportunity to test a sort of a natural laboratory setting to actually study to see if a high enough uptake in influenza vaccine in children could protect people indirectly. Okay, so we went through a series of pilot studies with the Hutterite community, and we've been actually working with them since about 2006, doing a number of these vaccine studies. So it's been really tremendous to work with, and in fact, some of these colonies, and mainly in Manitoba, were anti-vaccine, so we couldn't enroll them. There had been a number of colonies where there had been this huge debate between a naturopath and a pediatrician about the value of childhood vaccination, and unfortunately the pediatrician lost. So childhood vaccination just dropped to almost nil in Hutterite colonies in Manitoba, and there's still an effect there. But in the first year of the study, we were able to enroll some of the colonies in Manitoba. So the design of this study was basically randomizing the children in these colonies to either inactivated influenza vaccine or hepatitis A as a control. Okay, so they would get the children in a colony would get either all one, in another colony they'd get a hepatitis A vaccine. And this was the distribution of the colonies in Alberta, Saskatchewan, and Manitoba. And this is what the design looked like. So ultimately, we were able to randomize 49 colonies, 25 where the kids got inactivated influenza vaccine, 24 where they received hepatitis A vaccine, and we had 96, 97 completion of the study with roughly 3,400 people in the study. We vaccinated children between the ages of 3 and 15 because that's when in Hutterite communities the children were in school, and we really had we basically in the immunized children we excluded children who had any sort of adverse effect secondary to the vaccine, but in other Hutterite colonies basically anyone was eligible. So we included young children, people with chronic medical conditions, pregnant women, etc. The outcomes was the primary outcome was lab-confirmed influenza by PCR, which is really the gold standard today. And this is the bottom line. So by doing this study, we were able to show that in people who never got the vaccine themselves, they had a protectiveness of 61%, okay, which is the same level of protection that recent meta-analysis have shown if people get jabbed with a vaccine. So it was just very rigorous evidence showing that if you vaccinate children, and the uptake was on average was 80%, but it wasn't uniformly 80%. It had a range from anywhere from about 40 to 90%, but it was sort of a proof of principle that in an ideal setting, you can actually get high levels of herd protection. And when we looked at the total protection, that is the direct and the indirect effect, it was similarly almost the same, 59%. So this is sort of proof of that concept. So I think in summary, the ability of a vaccine to achieve community protection is really of important public health benefit, particularly given these really terrible infections that fortunately we don't see anymore. There are various mechanisms by which it could occur. You could have this sort of direct effect by an agent that's being transmitted to individuals who aren't vaccinated. Thresholds are acquired. They're mainly estimated by modeling studies, but in certain circumstances they can remain uncertain, and in that case it's really important to do these types of cluster randomized controlled trials that offer the most rigorous evidence for the benefit of herd immunity or herd effect. Thanks.